Session going. Thank you all for joining us. Good afternoon. I will ask that we begin recording so we can get started with our introduction on, we are going to record today's session so that we can refer to it and share it with other people in the future. Okay, so good afternoon and welcome to our session called Advances in Behavioral Healthcare Assessment and Clinical Treatment, Updates for the Case Manager's Toolkit, sponsored by the Fairfax Consortium for Evidence-Based Practice. I'm Janet Besmer, the Children's Services Act Program Manager and a member of the consortium planning team. Today's session is a continuation of a series of trainings offered by Healthy Minds Fairfax to increase and support the implementation and use of evidence-based behavioral healthcare interventions. We've been so fortunate to partner with George Mason's University's Department of Psychology for the past 4 years to offer a variety of trainings to clinicians in the private and public sector to enhance clinical services in our community. Today's session was developed specifically for case managers from across human service agencies to make sure we're providing updated information about best practices. We've learned from our university partner how important data is, and we did actually know that as well. Before we begin, we'd like you to click on a link in the chat and take a very brief pre-test to help us understand our participants' current awareness of the subject. And before the end of today's training, we're going to ask you to take a post-test to see if this training was helpful. So I'm going to pause now, send you to the link that just got posted, and ask for you to take a few minutes to fill out that pre-test. It's hard to know whether you guys are done or not when you're doing this virtually. I don't really see people's faces, so I can't really tell whether or not you need more time. So I am just going to give you about 30 more seconds, and then we'll get started back again.
It does appear that a number of you have not yet begun the pre-test. So if you have not yet done so, please click on that link and go ahead and start right now.
Okay, great, thank you. So for those of you who may have joined us a little bit late, after I gave the instruction, we're now in the zone of trying to do our pre-test. So click in the link and make sure you get that pre-test done so we have information to help guide us for future training.
The responses have just started to come in, so I'm going to guess that folks need maybe just 2 or 3 more minutes to complete.
Okay, great. Thank you for the update.
Your pretest is the link that's in the chat. There are a couple of you who asking where to find it. On the screen, you see an image of a chat with a 1, which was how you know where to find the chat. And then there's a link that was sent by Emma, and I can resend it just so that you have it again toward the front.
I just resent it again.
So for those of you, again, just click on those links and you'll be able to take that pretest. We really appreciate it. Okay, do you think we're ready to get started or we should give a little more time?
I would guess that people are wrapping up if you want to get started, because we have a little over half of the responses, which tells us that I think people are wrapping up.
Great. It's great that you can actually see that too, because I don't have any way of telling from where I sit.
Yes, thanks for your patience.
All right, everybody, thank you so much for taking the time to respond. That's really helpful to those of us on the training consortium as we prepare materials and develop them. This is the first time we are giving this training, so we really appreciate that feedback. And now I'm pleased to get our training started with a few remarks about the transformation in behavioral health care that has occurred in the past decade or so. We are very fortunate in Virginia to have so many evidence-based treatments that are being rolled out in our community in the last 6 months or so. And the trend of taking science to service is really critical in these changes and transformation we'd like to see in our community. And you as case managers play a very important role in coordinating care for families, monitoring progress, planning for transitions, and problem solving barriers that generally come up or can come up pretty easily. In order for our families to have voice and choice, and for it to be a powerful tool in their transformation, we really need our caregivers to have relevant information, updated information, and these really great choices for treatment. Our assessments help guide us to select the most appropriate level of care. So the level of restrictiveness for the treatments offered, the intensity, whether it's outpatient once a week, an intensive outpatient program, or maybe something like partial hospitalization or day treatment, as well as the type of treatment most appropriate for the individual's diagnoses and needs. So now I'd like to introduce our main presenter, which is Dr. Christy Esposito-Smithers, who's been an example of the role that universities can play in supporting communities' partnership in making these transformations. Dr. Esposito-Smithers is the Director of Clinical Training for George Mason's Psychology Department and has provided training to many clinicians in our community in the last few years as part of the consortium. She's brought her expertise in suicide prevention and evidence-based treatments to our team with the help of her two graduate students, Emma Whitmer and Anna DeFayette, who's helping us today, and we're very appreciative for their support. We are going to have one short break in the middle of today's training, and there will be opportunities for your active participation with polls and times to react in the chat. So now I'm going to turn it over to Dr. Christy.
Thank you for that very warm welcome, and it's a pleasure to be here today. Okay, let's get started. Okay. So I'm going to start out with a case study today just to orient us. So just carry along with me. Jessica is a 10-year-old female with a long history of treatment. She was adopted at birth and displayed significant conduct problems as a young child. She received play therapy for a few years. Jessica did not improve. In fact, she became worse over time. Her fighting, lying, stealing, and physical aggression toward her parents became more frequent. They discontinued play therapy and consulted with another therapist who was a good friend of one of their neighbors. This therapist told the parents that their daughter's problems likely stemmed from reactive attachment disorder and recommended attachment-based holding rebirthing therapy. During one of their daughter's sessions, two therapists and two assistants wrapped her tightly in blankets from head to toe, surrounded her with pillows, and restrained her. As she struggled to break free and cried for help, they continued to hold her down and waited for her to submit to her rebirth. After 70 minutes, the therapist removed her from the blankets. Jessica was cyanotic and breathless. She died the next day of asphyxiation at the hospital. Now, some of the early history may not be consistent with the case, but what actually happened in the context of therapy is a true case. This is actually something that happened in Colorado, and the therapists were charged with reckless child abuse resulting in death and sentenced to 16 to 48 years in prison. Now, this is an extreme case, but situations such as these underlie the need to test treatments using scientific methods. What one might think makes intuitive clinical sense may actually turn out to be harmful or not do any good at all. Though we have evidence-based treatments, it's still very common today to use treatments that may not actually work. And when we do this, clients may not improve and in some cases could even get worse. Today, we're going to be talking about evidence-based treatments that are available for use with your clients, as well as those to avoid. Okay. So our overall agenda for today is to spend a little bit of time talking about evidence-based treatments in particular. Then we'll talk a little bit about evidence-based assessment methods, measurement-based care. We'll do a little bit of case conceptualization. We'll learn a cognitive behavioral case conceptualization together. And then we'll talk about treatment matching to treatments that are available in your community. Okay. So what is an evidence-based treatment? They're treatments that have been tested in research studies and shown to work. We typically test treatments in what we call randomized controlled trials. That's where we test what we call an experimental treatment or a treatment that we've developed and compare it to a control group. And typically what that is treatment delivered as usual in the community. So children and their families will be randomized to one of the two treatment condition arms, either the experimental treatment condition arm or the control condition arm, and then they're followed over the course of time to see who does better. This type of use of randomized controlled trials to test treatments is very consistent with the medical model that we know very well when we test drug treatments. So we're testing our therapies much in the same way that we test different types of medications that come to market. Importantly, the list of evidence-based treatments change as interventions are tested. So the more studies that are done to test various therapies, the longer the list grows. Many times we have treatments that are added to the evidence-based treatment list that have support, but we also have treatments over time that have been added to the treatments that do not work or treatments that might actually harm list, which we'll talk about today. Now, the use of evidence-based treatments represents a best practice and a preferred approach by the American Psychiatric Association, the American Psychological Association, and many other various organizations. Okay. Now, there's two different types of trials that treatments are tested in research. There's efficacy trials, and then there's effectiveness trials. In efficacy trials, these are studies where the treatment, the experimental treatment, is tested in research settings by highly trained study therapists. They tend to be very tightly controlled trials. Then, based on the results of the trials, the therapies are categorized into one of 5 various categories, anywhere from the results suggested that the treatment did not work, all the way to it becoming a well-established therapy, depending upon the amount of evidence that's available. So when you're looking for different types of treatments in the efficacy literature that you might try, you probably want to be looking for treatments that are at least probably efficacious, if not well-established. The difference between the two being that there's some evidence for one of the treatments in one trial, when you're thinking about probably efficacious treatments, to more than one trial in well-established therapies. Actually 2 trials conducted by more than one investigative team. But also note that there's also the experimental therapies category there. And these are treatments that may actually be in use in our community, but they've not been studied carefully. So we don't know whether or not they work. Then we have our effectiveness trials. Now, effectiveness trials are trials where the treatments are tested in community settings and delivered by therapists actually employed in these settings. And similar to the efficacy trials, there are 6 different categories that these treatments may fall into. If they actually have a negative effect in the trial or even cause harm, they're considered a concerning practice, all the way up to a practice that's well supported by research evidence. So when you're looking at the effectiveness studies, at the very least, you want to be looking for treatments that have at least some promising research evidence, if not supported by research, because at that level, the treatment's been tested in a clinical trial. There's also, just like the efficacy research, a category which is not rated. And those are treatments that are generally, in use in various communities, but don't have any data behind them. Doesn't mean that they don't work, but it doesn't mean that they do. It just means that we haven't tested them, so we don't know what they do at this point. Okay, so I'm going to stop for a minute and we're going to take a quick poll. So what therapies do you most commonly refer children and adolescents to for treatment of PTSD or trauma? If you could please just take a minute to complete the poll that appears on your screen. Okay, we're almost there. We have 86% of people who voted. A couple more people. We're up to 90%.
And Christy, I think the last 4 may be the 4 of us.
Okay, well then we'll stop there. Okay, so we have the majority of folks who are making referrals for trauma-focused CBT. Next, we have play therapy at about 23% of folks, followed by a tie for EMDR and PCIT. Great, thank you for sharing. So let's see what the clearinghouse looks like. Okay. So these are the levels of research support for various treatments for trauma and PTSD that have been tested in effectiveness studies, and these are published by the California Clearinghouse. There's various organizations that review the research literature and then place various treatments that have been tested into the research categories. California Clearinghouse is one of those. So if you look at the various categories, you can see that TF-CBT, prolonged exposure therapy for adolescents, and EMDR are well supported by research evidence per the California Clearinghouse. And you can, if you go down, you can find the other types of therapies. You can see that we have some that are in use that are not rated yet. So the trauma-focused integrative play therapy, which a number of you endorsed, is one of those treatments that may work, but it's just not been tested in research as of yet. So it's unclear as to what degree or where the results would fall if it's tested, but it's something that sounds like needs to be tested in the literature because it's being used. Okay. Now, because sometimes the clearinghouse lags behind with regard to research results, what I actually did for trauma and PTSD is look at the National Child Traumatic Stress Network website and looked for other randomized clinical trials that may have been published and not yet included in the clearinghouse. And when you do a much more comprehensive review, these are some of the evidence-based therapies that have the most evidence to date for kids at various age ranges. So child-parent psychotherapy is one that's just come out and has shown some really nice research evidence for kids from the age of birth all the way up to age 6. Of course, that's going to be a parenting intervention. Then we have parent-child interaction therapy, trauma-focused CBT, which most of you actually said that you're making referrals for. And that's good for kids ages 3 to 21. As well as alternative for therapies, a CBT approach, which is a treatment specifically for parents who have abused the children and their kids. We have CBITS, which is actually used, I know, in Fairfax County school system, and then trauma and grief component therapy. These are some of the treatments with the most evidence to date for trauma and PTSD. Okay, so let's take another quick poll. Which of the following therapies are you familiar with? Okay, we almost have everybody.
And I'm realizing, Christy, that I didn't include a none box, so it's also possible that a couple of people are not familiar with these.
Okay, so well, then we can go ahead and stop the poll. Great. So it looks like, I would say, the majority of people are familiar with the attachment-based holding therapy. And then another technique is deprivation of basic needs, which is a type of, it's a type of attachment-based holding therapy that also includes neglect of food and clothing and things of that nature until the child complies with what's being asked. Conversion therapy and aversive conditioning. So people have heard of many of these therapies. Okay. Now, these are examples of what we found in the literature to be potentially harmful treatments. And I'll talk you through what's been found in the literature to date. So we have multiple ways of categorizing treatments as treatments that don't work or could potentially be harmful. You know, there's a lot less literature on potentially harmful treatment than there are that literature for treatments that work well, but they're equally important to know when you're making referrals for treatment. Okay, and some of the ways that potentially harmful treatments are categorized are by looking at the research studies that have been conducted and taking a look at the numbers and different types of adverse events that occur during the study. So those are things that might happen to the child or the family that are very negative in nature. Adverse childhood experiences, to look to see the degree to which those various types of things occur in the context of the studies. There's also quantitative results from research studies. So those are the research assessments where people are followed from start to finish and then months out. And then there's also what are called Delphi polls. And those are studies where experts in the field will complete surveys, and the results of those surveys are pulled into one research article. Okay. So this is a study that was published by Jane Mercer in the Journal of Child and Adolescent Social Work. It's a recent study where she reviewed the child and adolescent literature with an eye towards potentially harmful treatments. And what she actually found is that the attachment-based holding therapy, the attachment-based adjuvant methods, and that's the one where you actually engage in deprivation of basic needs until you gain compliance. The aversive conditioning conversion therapy, and then Gestalt therapy is another type of treatment where there have been a number of adverse events reported in the context of those research studies. So you can see the various types of harm. In when studied child death, things such as weight loss, suicidality, increased risk for depression, increased risk for anxiety. Now, when you look at those studies and you categorize them by the presence of ACEs, you can see that the various types of therapies have evidence of things such as insulting the child, humiliation, fear of physical attack, and things of that nature. And then also these studies were also rated for criteria from NIS-4, which is another system of child abuse and neglect reporting. And you can see that some of these therapies, if you code what occurs in the context of the therapy, it could be construed as physical neglect, abuse, educational neglect, or emotional abuse. Okay. You can also look at the quantitative results of the studies. You can follow people and look at how they do over the course of time. And for some studies, you can find that the studies have shown harmful psychological or physical effects in either the client or even others. So for example, recovered memories of abuse that tend to be false can cause a great deal of harm to relatives. So that's an example of how a treatment can actually not only harm the client, but also harm others. Studies may also show that the harmful effects are enduring and do not merely reflect a short-term exacerbation of symptoms during treatment. And harmful effects for some types of treatments have actually been replicated by independent investigative teams. Okay, so Lilienfeld in 2007 published a review article of treatments that are potentially harmful that ranged from studies conducted with kids all the way to adults. His review hasn't been updated yet, but it's received a lot of comments. And these are examples of studies that he actually listed in the context of his review. So you may all be familiar with critical incident stress debriefing. That's a pretty well-known treatment that we thought might actually show some pretty good results when we first started using it. Many people have been trained in it. But what the long-term studies have actually shown is they actually increase risk for PTSD symptoms, not decrease risk. Then you also have programs like Scared Straight, facilitated communication, that rebirthing, holding therapy that I gave a case example of earlier, recovered memory techniques, dissociative identity disorder-oriented therapies, expressive experiential therapies. Although I'll make a note about that one. That was some studies conducted with adults. And what they concluded in that study is that the therapists worked on helping people express their feelings, but then they never helped them work through how to manage those feelings that had come up in the context of treatment, which is why it didn't have a positive effect. Also, boot camp interventions for conduct disorder and DARE programs are also on the list. Okay. Other things to think about with regard to using treatments that don't have an evidence base yet is that they could potentially waste family resources and delay or prevent the use of effective treatments. Clients may actually get worse over time without effective care, and they've not been tested, so you can't conclude that they're safe or effective. It's entirely possible that they could be, and there may be folks who have been using these treatments for long periods of time, and they have shown, or they have seen their clients get better, but we just don't know from a scientific standpoint how they're going to do. Parents are also not likely aware of the evidence base of treatments or possible harm resulting from treatments, which is something to think about as well. So in order for a parent to know whether things like abuse is occurring or ACEs or things of that nature, the child will need to disclose some of those things, and that's not always the case. Interestingly, because we've seen this potentially harmful treatment literature evolve, as well as treatments that haven't shown to work, the National Institute of Health is now funding what we call de-implementation research, where NIH is basically providing monies to clinical researchers to help various systems and organizations do away with treatments that have not been tested or shown not to work and replace them with evidence-based treatments. Okay, and this is only made possible because the science is continuing to grow and we're continuing to learn about what we're putting out there. Okay, so why keep up with evidence-based treatments? Well, so that you know that you're offering the best level of care currently available to your clients. So this is really going to require you to compare the level of research evidence available for a treatment at any given time for the different types of mental health problems that children and families present with. Okay. Importantly, use of evidence-based treatments are also consistent with our ethics code, whether it be the American Psychological Association, NASW, or NASP. All of these various organizations support the use of research to inform clinical practice in an effort to avoid doing any harm to our clients. Okay. Testing, studies, and research also allows for true informed parental consent. So testing, interventions, and research allows parents to know what has evidence behind it, what doesn't, what are the potential outcomes if a various type of treatment is used. In the medical field, we do this all the time. Parents are presented with an informed consent form when a doctor presents a procedure. So parents know about the various options for different types of problems. They know the risks associated with the use of various procedures, as well as the potential success rates. Well, we're at a place in science now where we can present some of these data to families as they're selecting treatments for their children. These studies also arm parents with knowledge about untested treatments, potentially harmful treatments, as well as effective evidence-based interventions. And importantly, when engaging in these discussions with families, you also want to talk about the use of treatments that are not validated for a particular age group. For example, it's not uncommon for individuals to use adult interventions or treatments that have developed for adults in particular with adolescents or even with children in some cases. And we know that there's vast developmental differences, so that the results will not necessarily translate if they worked well with adults. The same treatments may not work very well with adolescents, and usually not at all for children. And of course, as we know, informed consent is required by our ethics codes as well. Okay. So now I'm going to move into evidence-based assessments. Now that I've provided a broad overview of evidence-based treatments, the science behind it, and how we test it, hopefully you have a better idea about where the field is at this point in time with regard to our ability to test interventions and how to use various systems that are in place to help select interventions. Now I want to spend a little bit of time talking about evidence-based assessments. And evidence-based assessment is the use of a standardized assessment instrument or tool that has adequate psychometric properties, which basically means that the assessment has been tested in research with the populations of interest and has been shown to measure what it's supposed to measure. Okay. I'd like to start this discussion area out with a quick poll as well. So Ann and Emma, if you guys can post the poll, we're just interested in knowing which types of assessment instruments that are listed here that you have been exposed to or that you've heard of before. Okay, so why don't we stop voting at this point? We have just about everybody. And good news is most of you have heard about the Columbia, which is a widely used and available tool. All these tools are actually free and widely available. About half of you have heard of the CATS, which is a superb trauma measure. And then it ranges from there. Very little knowledge of the diagnostic interviews, which I'll talk about in a minute. Great. So you've had some exposure to some of these free and widely available assessment tools. Let's talk a little bit more about them. Okay. Now, not surprisingly, our ethics code also dictates the use of assessments that are backed by research, attesting to their reliability and validity. And the tools that you just noted, whether or not you were familiar with them, are examples of evidence-based assessments with a large body of research behind them. Now, is evidence-based assessment commonly used in practice settings? Not all the time. In fact, standard practice is the use of an unstructured clinical interview to derive diagnoses instead of validated, semi-structured, or structured diagnostic interviews. And we know from the research at this point that the unstructured clinical interviews tend to be less accurate, less likely to identify co-occurring conditions. They have limited empirical support, and may be subject to various biases that decrease assessment accuracy. Okay. Diagnostic interviews also allow for brief screening of multiple diagnoses so that problems not shared during the clinical interview are not missed. They include screens at the very beginning, so you actually touch on all the various types of psychiatric disorders that youth might experience. And if the kid says no to one of the first 2 questions, then you don't go through the rest of them. So it's a really nice, quick way to go ahead and screen for different types of problems that could be underlying the presenting problem or what parents share. Diagnostic interviews also yield more valid and reliable diagnoses than standard clinical interviews in the literature. They also improve one's ability to make differential diagnoses. And research also suggests, of course, that accurate diagnoses will then, in turn, improve our ability to develop an appropriate case conceptualization, select appropriate evidence-based assessments for monitoring, as well as select appropriate evidence-based treatments. Okay. Now, differential diagnosis is incredibly important, as I'm sure you all know, because comorbidity is the norm rather than the exception. And it's really important to know whether a child has one diagnosis that shares multiple symptoms across others, or whether the child is actually exhibiting multiple types of psychiatric disorders. Take trauma, for example. Symptoms of PTSD overlap with many different disorders, and if untreated, may pave the way for additional disorders. Okay, so if a child exhibits trauma and it's untreated, they may end up developing many other disorders like depression, anxiety disorders, eventually suicidality, and substance use disorders. And unfortunately, it's not uncommon for teens to have multiple diagnoses and never had a trauma diagnosis or treatment, even though they had it and it was one of the first problems that they exhibited. That's why it's so incredibly important to do careful screens. Importantly, not only should we be thinking about using semi-structured or structured diagnostic interviews, but also making sure to incorporate not just the parent's point of view or the kid's point of view, but both the parent and the caregiver, as well as any others who interact with the child when at all possible. We know from the research that relying on one informant's report can lead to different diagnostic conclusions than using a consensus rating from multiple informants. Research also suggests that parent and child ratings of various social, emotional, behavioral issues are often discrepant, and this gap increases from childhood through adolescence. So the older the kids get, the less likely the parent and kid report is likely to concur with regard to the types of problems the kid is exhibiting. Then we also know that misdiagnoses and problems resulting from use of one informant actually will influence the treatment target and subsequent outcomes for the kid. So if you miss things like an underlying anxiety disorder, which is not hard to do because oftentimes a kid will come in with a disruptive behavior disorder or depression, and the parent nor the kid will talk about an underlying anxiety disorder, which really complicates the treatment for the problem they've brought in, but also needs to be addressed for the kid to get better. So these are various examples of diagnostic interviews that are free and available. Well, actually, the mini is not free. The mini is $10 a pop, but the other ones are actually free and available. And these are the ones that we recommend through the consortium trainings. We're actually considering doing a training in the consortium on semi-structured and structured diagnostic interviewing for those who are interested. So please stay tuned for that. Okay. And then I also just briefly wanted to introduce you to a number of other evidence-based symptom inventories that are available and free to the community. They're actually very commonly administered in pediatric practices. We see them used a lot less in mental health settings than we do in pediatric practices. So many of you had endorsed that you're familiar with the PHQ-9A. That's a very common depression screen. The SCARED is a very widely used anxiety screen. The Vanderbilt assessment scales are also commonly used in pediatric practices. Okay. There's also very brief eating measures, alcohol use measures. The audit tends to be very commonly known, as well as the DAS for drug use. And I was happy to see that the majority of you are very familiar with the Columbia Suicide Severity Rating Scale, which is also free, widely available. And there's also a free training available on the website. Now, trauma is no exception. We have many, many well-validated trauma screenings. The CATS is one of the most popular and widely used. It actually comes in English and Spanish. And it's really nice because it includes a screen, it measures symptoms, but also a degree of functional impairment. So it can really give you an idea about how severe the kid's symptoms are and let you know whether or not they likely meet criteria for a full-blown PTSD diagnosis. But there's a number of others that are available, and they've actually been adapted to the DSM-5 already, which is great. Okay. So based on all of this information, next time you're assigned a case, here are some questions to ponder. Does the child have an assessment? Are evidence-based assessments used? Are all potential areas of difficulties assessed? Are reports from multiple informants included? Do you have a report from the child, from the caregiver, from the teachers? Or does the child need more assessment to make an informed choice about the referral? Just some questions to ponder. Okay, so now we'd like to hear from you. How do you currently know if a child that you have referred for treatment is benefiting from care? If you can go ahead and use your chat function and let us know what you're currently using as your metric. Or if you're actually following your cases, if you know if they're benefiting from care. How do you know? Okay, self-report. So some people are saying that they see some self-reports, maybe in assessment reports that they get. That's great. Symptom behavior reduction. I'm assuming that's from assessments. Okay, so consultation with the therapist. HUDAS. 90-day reviews. Okay, so for folks that are saying decrease in symptoms, what tools are you seeing? What tools are you seeing in reports? What assessment tools? Good, we've got a CANS in here. Yep. DLA 20, 90-day reviews. Okay. What assessment tools do you typically see in reports? See the CANS. Okay, some rating scales. Okay, so it sounds like the NCFAS, client paired satisfaction ratings. Okay, so that can be an important part of assessment, is how satisfied with services as well as symptom reduction. Okay, great. So it sounds like there are some self-reports that are being administered. They listed a couple of them. So that's good that some are being used. So what we'd like to see, oh good, okay, we've got an example of the Beck Depression Scale, the SCARED. Okay, wonderful. So somebody's done match, is using the match measure. So that's awesome. Okay, thank you. So what we're hoping you're going to be able to do moving forward is to engage in what we call measurement-based care, which is an evidence-based practice that allows you to track how clients are doing over the course of time. And that's really going to depend upon the assessment tools that the therapists, that the kids that you have referred to are using in the context of their practices. So let's talk a little bit about what measurement-based care is. It's the systematic use of patient-reported data to inform care decisions and monitor treatment progress, as well as provide feedback to clinicians and clients. Okay. So you essentially, you give the child and the parents, if you have parents in treatment, an assessment instrument, they complete the assessment instrument, you score it and you track it, and you use that to see how the client is doing over the course of care. The research actually suggests that use of measurement-based care, or regular administration of evidence-based assessments to track change over time, leads to a faster reduction in mental health symptoms, particularly when used regularly. So it actually works a lot better when the kid and or the parent complete an assessment session to session versus every 90 days or so, which is common with treatment reviews. So the more frequently it's used, the more helpful it is. It's actually been shown to improve patient-provider communication. It improves patient engagement and improves clinician treatment fidelity. It actually also lowers the cost of care because kids tend to get better when measurement-based care is used quicker. And as a result, it'll lower the cost of care. And as you can imagine, if you see that the scores are getting better, then the clinician will stay on the course of care. If you see that the scores are getting worse, that sends a message to the clinician that something has happened or the course of care may actually need to change slightly. So it really helps guide clinical decision-making, which is incredibly helpful in treatment. As a result, measurement-based care is actually required by many major accrediting bodies of health organizations at this time. It also offers protection against potentially harmful treatment. So if a kid's in treatment and you see that the scores are getting worse and worse on a weekly basis, then you know that that's something that the kid is not necessarily benefiting from. Now, in our core competency cognitive behavioral therapy protocol, we have measurement-based care integrated into the treatment protocol, and we just have a brief screen that taps depression, anxiety, anger, and sleep, as well as self-harm and substance use and medication compliance. The teen is handed a questionnaire or via telehealth. It's projected on the screen or emailed to the kid completes it. The clinician can score it within a minute or so. There's also an accompanying parent version because we know that it's great to get multiple informant report, and oftentimes there may be times when the kid may not report things, but the parent is more willing to report things. And in those circumstances, you get a better sense of what the clinical picture is. So if you can have both of them complete the measure, that's ideal. The clinicians then go ahead and score up the measure. They enter the score into an Excel spreadsheet, which we provide to them when we give them the treatment protocol, and the Excel actually just graphs the scores. And so this is an example of what the graph might look like. And this is a kid who's doing really well in the context of treatment. You can see that the scores are going down generally over the course of time. There might be weeks when there's slight peaks, and that'll let the therapist know that something might have happened over the course of the week that needs to be processed. But generally, you can see a nice linear decrease over the course of time, which shows you that this is a successful course of treatment for this kid in particular. Provides really nice feedback to the clinician. It also provides nice feedback to the family. Okay, so this is an example of what measurement-based care might look like. So how do you think the youth and caregivers you refer for care would feel if they received this type of information during therapy sessions? And would it affect your referral practices, if at all? So let's chat it out. See what your thoughts are. Let's start with the first one. How do you think the youth and caregivers you refer for care would feel if they received this type of information during their therapy sessions? Would they like it? Would they not like it? Or if you're not sure, think about how you might feel or a loved one if you took a loved one to treatment. Okay. Okay, so far folks are thinking the families might like it. They'd feel more involved. They'd have a voice. Absolutely. Yep, some might like it better than others. Yeah, what the research is showing with the teens in particular is if they feel like what's being assessed is applicable to them, they tend to really like it. Yep. And it really does give voice to the families because you can share, what the results are looking like, and then you can work together for treatment planning moving forward. Yep, a good way to track progress. Parents have better understanding. Absolutely. Okay, great. So generally folks think that this might be something that most families would like. Some might like it better than others, but helpful information. You can see how it might increase engagement. It might better involve the parents and the kid in the treatment decision-making process. And then how do you think it would affect your referral practices if with the cases that you referred, you actually got these types of reports where you had nice information from evidence-based assessments about how your client is doing over the course of time? Would you use those data? But I'd love to have that. Yep. I have a lot of that would be great. Yes.
Christy, there's a great point in here that came in one of the heavy chat influxes about how it helps inform level of care based on symptom
Absolutely.
presentation.
Yep, absolutely. It really does help inform level of care, particularly when you're in a multi-service setting where they have your PHP and your IOPs and your outpatient settings. You can move kids up and down to the appropriate services based on their level of symptom presentation. Okay, great. Okay, thanks for your feedback. So we've done a pretty brief overview, but at least oriented you to the literature about how we assess treatments and also where the field of assessment is moving. Spent some time introducing to you some widely and free and available assessment instruments and how they can be used in the context of measurement-based care. Okay, so on that note, I think we are going to take a brief break. Why don't we go ahead and take, would you say a 10-minute break? Come back at 2:05. We're going to go ahead and pick up from here. Okay. Now what I'd like to do is pick up by talking a little bit about the use of assessment to guide case conceptualization. Now, for those of you who have gone through the core competency training, please bear with me because I know that you have learned this case conceptualization and could probably be the one presenting it here today. But for those who are new, this is a nice way to think about your cases. Now, when we do a cognitive behavioral conceptualization, there's multiple levels to consider. So there's the presenting problem or what the client typically brings in.
Permítame llamarle de nuevo dentro a las 3, ¿ok? Porque están hablando y no les oigo y me van a pedir algo en un momentito.
Christy, if you just want to go ahead and unmute yourself, I just muted the entire room. So you can go ahead and unmute and you'll be able to continue on.
Okay, thank you. Can you hear me?
Yes.
Okay, great. Okay, so I was saying this is a cognitive behavioral conceptualization, and at the heart of the conceptualization is the presenting problem, or what the child and family shares is one of the primary sources of difficulties that they're experiencing. You do a thorough assessment and you're able to derive diagnoses. Each of those diagnoses are associated with a host of symptoms. Those symptoms are in turn influenced by context or setting. Culture is a large part of that context. And so I'm going to talk a little bit about each of these areas, but they're all very interrelated and all must be considered in developing a case conceptualization. Okay. So as I noted, diagnoses are associated with a whole host of symptoms. There's physiological symptoms, mood and affective symptoms, behavioral symptoms, automatic thoughts or cognitive symptoms associated with various diagnoses, as well as a set of common interpersonal interactions. And those all must be considered when deriving a diagnosis. Importantly, they also all affect one another. Okay. Now, context influences the expression of those various symptoms, which in turn influences the diagnoses that are derived. Okay, so symptoms tend to be associated with a whole host of cognitive structures and dispositions. So these are things like automatic thoughts, underlying assumptions the client might experience, core organizing beliefs or personal meaning structures that the guide one's view of self and in how information is processed, as well as various types of cognitive distortions. Relationships influence symptoms, within the family realm, the peer realm, and school realm. There's also history and development that needs to be taken into consideration and will influence symptoms. So that's going to be things like the child's temperament, various activities the child's engaged in, history of school performance, disciplinary practices, previous treatment, physical health, family, medical, and mental health, legal involvement, all those types of things will play a role in symptom expression, as well as behavioral antecedents and consequences. So what types of things are preceding the problematic behavior and what types of situations are following it that might actually serve to reinforce it. Same thing with symptoms. All of these contextual factors interact with one another to influence the symptoms, okay? And as I noted, a really important component of context is cultural factors. So the socioeconomic status of the family, their various identities, customs, values, and beliefs, religion, degree of acculturation, as well as various adversities they might have faced, like oppression, marginalization, and discrimination. All of these contextual factors also interact to influence the symptoms, which in turn influence various diagnoses, which in turn influence the presenting problem. Okay, so this is not necessarily an exhaustive list of all the cultural contextual factors to consider, but provides a nice overview. Okay, so now keeping that in mind, thinking about all of the contextual factors, I'm going to present part of a case, and I want you to tell me, you can chat it out in the text, what type of referral you might make for this case. Okay, what do you think this child might be exhibiting and what type of treatment you might refer the kid for. This is say that you're presented with a case of a 10-year-old child who reports constant worry about school performance, family finances, health of her family, her safety, being made fun of by others, her future, the future of people she cares about, her pets, all of which impairs her ability to perform well at school and form relationships. She also reports headaches, upset stomach, and trouble concentrating. So you can see a lot of cognitive symptoms, a lot of mood symptoms, a lot of physiological symptoms that she's experiencing. So just looking at that information alone, what do you think might be the presenting problem or the type of diagnosis she's experiencing? Anxiety. Yep. Any specific type of anxiety? Yep. A lot of anxiety. Looking at the nature of all those anxieties, absolutely. Generalized anxiety, yep. Okay, great. So we have a lot of anxiety, a lot of generalized anxiety, which it seems like she has a whole host of worries and it's causing very significant impairment. Now, what if I also told you that she's from a family that has very low socioeconomic status. Her parents are immigrants. Her dad just lost his job. Mom has a heart condition and does not have the money to see a doctor. The child is missing school to care for mom. The kids at school are making fun of the child for wearing old, torn clothing. The child lives in an unsafe neighborhood and the family can't make rent payments. Do you still think she has generalized anxiety once you know all of these contextual factors? What do you think? Does she have GAD? Yeah. Yeah, so she might still have some anxiety, but if you look at her worries in the context of her home situation, these are not unrealistic worries that she's experiencing. With the health of her family, she's got an ill family member. She has real worries about whether or not she's going to be in her home, she's going to be able to perform well at school because she's missing so much of it. So she's worried about real world issues that have a strong basis in reality. So yes, she may have clinically significant anxiety, or maybe these are more reality based and the treatment really needs to be focused on helping the family system, as well as helping her cope as best as she can in that situation. So this is just a prime example of how, again, additional assessment would be needed under these circumstances, but also how context really influences the way that you think about the presenting problem of the child. Context is really incredibly important to know in order to make appropriate, accurate diagnoses, conceptualize a case, and form an appropriate treatment plan. Okay. Now, many of you use the CANS, the Child and Adolescent Needs and Strengths Assessment. And the CANS is a really nice tool because it actually captures a lot of what you, the data that you need to gather in the context of a cognitive behavioral case conceptualization. So you've got the life domain functioning factor, the child's strengths, and the caregiver strength scales. All of those ask questions that tap really important contextual factors that are important to know when conceptualizing a case and deciding on an appropriate treatment. Okay. And then the risk behavior scale also taps multiple types of symptoms consistent with various types of behavioral difficulties. And the behavioral and emotional needs subscale also taps various types of symptoms as well as potential diagnoses that the kid might be experiencing. So you have a really nice, helpful assessment tool that you can use to gather information about your cases that does take into account significant contextual factors. Okay, so I have another question for you. So say you get a case and the child has sought treatment before. What do you need to know about treatment history to make an effective referral given what you've learned so far? What's going to be important to know about the kid's treatment history before you make a decision about where you're going to refer the kid? Aside from whether or not the treatment was helpful, because that's a pretty obvious. What other types of things do you need to know about, regardless of the helpfulness of the treatment? What do you need to know about? The type of treatment, yep. What methods were used? What was the treatment? The treatment included family stressors, good, yep. What else? Length of time, absolutely. Did it work? Didn't it work? Mm-hmm. Are they currently in treatment, taking any medication? Absolutely. Family motivation, yep. How well did the family engage in the prior treatment? And what is their current motivation moving forward? Anything else you want to know with regard to the treatment history before making decisions? Child's perspective. Mm-hmm. Yep. Why discharge from treatment? Absolutely. Okay. What barriers? Yeah, that might actually dictate the treatment moving forward. If they weren't able to make it to the office, you might make decisions differently. Yep. What was recommended after discharge? Absolutely. So these are all great things that you want to know. And many of them, many of the things you've actually hit on already. So what type of therapy did the child receive? That's something you're going to want to know. Was it actually an evidence-based therapy? Was it delivered in its full form? I mean, how many times have you had a case where a kid presents and they say, oh yeah, I've already tried CBT and it didn't work, or I've already tried, this type of treatment and it didn't work, only to find that they only attended 3 sessions, or that they attended it with a provider who didn't necessarily know how to really do CBT or really know how to do TF-CBT or whatever treatment you referred them to. Then the child may not have actually had an adequate dose if they didn't stay the course, or if the person providing the therapy didn't know the therapy all that well. You're also going to want to know whether or not, an adequate dose was received. What skills the child learned might be a good question to ask. Were the caregivers involved? If they weren't involved, it's entirely possible the child actually didn't have an evidence-based treatment. How helpful was the therapy and how was this determined? Were evidence-based assessments used to help determine whether or not treatment was helpful? Did the therapy match the presenting problems and levels of need based on the assessment, the case conceptualization, and the treatment history? I mean, did this kid have this very significant history of trauma with multiple comorbid conditions and only receive, a very brief type of therapy? That's going to be a very significant mismatch. And then also, do you need more assessment data to make a good referral moving forward? really there's a whole host of things that you're going to want to consider when you get a case and you have to find treatment for a kid and they've been in treatment before. Many things to consider to determine whether or not the prior treatment actually was the appropriate treatment for the kid. Did the kid actually receive the appropriate dose, and was it with a provider who knew how to deliver the therapy with fidelity? And what more assessment data do you actually need to make a good decision? All things to think about. But your job is not done, of course, after you make the referral. It's going to be important, if at all possible, to know how the child is doing after the referral to see if you need to make a new referral or if things are going well. So is the provider administering the CANs or another assessment to track treatment progress? I mean, how are they determining whether or not the kid is getting better? Is the provider sending you the data to review during specified review periods? That would be wonderful if that was something that was happening. Are the child and caregivers attending sessions regularly? Really important to know, because there's no way they're going to get an adequate dose of treatment unless they are. Is the child making progress? Are you seeing a decrease in the risk behavior, a decrease in suicide attempts, self-injury, or delinquent behavior? Are you seeing improvement in emotional and behavioral functioning, things like depression, anxiety, substance use, and conduct problems? Or do you need to change this treatment plan? So a whole host of things to consider. Okay, so let's take a couple minutes now that we've talked about assessment, measurement-based care, case conceptualization, referrals, and what to think about with regard to tracking progress over time. Let's talk about what you actually have available in your community. Okay, so I would say most of you have seen this job aid, which lists the various types of treatments that are available in Fairfax County for our kids. And what I've done here actually is, like I said, you've seen the job aid. I'm sure you've all heard the majority of the treatments before. What I've done here is I've put this information, I laid it out in a structured way, slightly different than what you see in the job aid. You can actually use these slides as a reference moving forward. So I'm not going to spend time going through the various specifics about each of the treatment, but I've laid it out in a way that I hope is useful, user-friendly, and helpful to you. So for each of the types of treatments that are available in the community, I've laid out the age, the different types of problems that are targeted, effectively targeted in the context of the treatment, the exclusion criteria, the requirements, as well as CSA authorization, if it's needed at all. So we have parent-child interaction therapy available for our young ones. We have the modular approach to therapy using cognitive behavioral therapy for children with anxiety, depression, trauma, and conduct problems. I mean, this is a really great treatment for the little ones with oppositional defiant disorder or conduct disorders. It also does a really nice job with depression and anxiety for kids as young as 6. And again, this is going to be one of those treatments where there's a very large parent component to treatment. In fact, with the young ones, for effective treatment of disruptive behavior, sometimes you don't even need the kid in the room. You can do the treatment with the parent. It can be helpful to bring in the kids so the parent can practice the use of the skills in front of the therapist. But for many kids, for the young ones, they don't necessarily even have to be in the room. The treatment can be done with the parents. Okay. This treatment, you can also use it for trauma, but if trauma is primary, we strongly recommend that you use something like TFCBT that was specifically designed to treat trauma versus using this treatment. Okay. You've heard of the core competencies and cognitive behavioral therapy, and this is for older teenagers, ages 12 to 17. It taps a whole host of problems as well. And again, if trauma is the primary presenting problem, we strongly recommend that you use TFCBT for the referral source as opposed to the core competencies protocol, but it can accommodate kids with trauma. Okay, we've listed the exclusion, various treatment characteristics. Okay, dialectical behavior therapy. These are all the various characteristics for DBT. Importantly, we've highlighted here that it's really important for the caregiver to be involved in the family-based sessions for the most effective treatment outcomes. And then for DBT, the kid has to be willing to reduce risky behaviors at the start of treatment, although I know the therapist does work with them around that, but that's a really important component of treatment. They have to be committed to getting better. Then you've got your trauma-focused cognitive behavioral therapy. And what I've highlighted here is that TFCBT is really for families where where the caregiver is not the offending caregiver. So that's something to keep in mind, but there's a large parent component to TFCBT as well. Okay, functional family therapy. So of course the parents or caregivers need to be involved in functional family therapy because it is family sessions for this type of treatment. And it's for kids who actually live at home or have been scheduled to return home. It can be used to address a whole host of externalizing types of behavior. It can be used with kids who have depression and anxiety, but it's with some type of externalizing behavior. And that's really important to remember. It's not, you wouldn't refer a kid with just depression or anxiety or both of those for functional family therapy. It's really designed for kids with the externalizing stuff on board. You've got multisystemic therapy, which is a much more comprehensive and intensive treatment than functional family therapy, really geared toward addressing externalizing problems as well in kids ages 11 to 18, again, with a large caregiver component. Okay, so what we thought we would do, because you can see that many of the treatments that we presented actually have some overlap with regard to the types of problems that they accommodate, we thought that we would just provide a little bit of information about how to decide amongst a couple of the various types of treatments. So how do you know when to refer for functional family therapy versus multisystemic therapy? They're both really designed for kids with externalizing problems. Now, one way to think about it is that if the teen's behaviors are primarily rooted in family issues or in psychiatric concerns, the kid, you might choose functional family therapy. But if the teen behaviors are primarily rooted in peer, school, and or community influences, MST might actually be a better choice. It can also accommodate family issues as well, but it does a really nice job addressing problems in other areas outside of family as well. You would also make a MST referral if the teen's problems are more severe and chronic in nature, because it really is a much more intensive, longer term treatment, much more comprehensive, many more hours. What about core competency or DBT as far as suicidality is concerned? Core competency CBT is really for those kids who may have suicidality on board, but they can be managed on an outpatient basis. It can be like a session a week, or it can be a couple of sessions a week. Whereas the dialectical behavior therapy, it can be used for kids with one or more instances of suicidal behavior, but typically kids where the suicidal behavior is more chronic, or non-suicidal self-injury is more chronic and severe. So core competency is like CBT light, DBT is CBT heavy, more comprehensive treatment. Okay, and then what about trauma? Where would you go first? So we would recommend that you go to, that you refer for TFCBT for treatment of trauma, given that this is the treatment that's actually been shown to have the most evidence in the literature across folks from a range of cultural backgrounds and with kids from a range of ages, all the way from ages 3 up to 21. And then as more evidence-based treatments become available in the community, branching out to make other referrals as well. But right now, TFCBT is one of the best that we have. Okay, so you might be asking, or maybe you're not, what are the commonalities across all approaches? Well, you may have noticed that all of them require, or at the very least, strongly encourage parental or caregiver involvement. So it's really important to know that effective treatment for kids living at home includes a caregiver. Kids exist within systems. Family system is a really important component. The parents serve as gatekeepers, and parents can be very, very helpful with regard to getting the kid better. And there may oftentimes also be things that need to be worked on in the context of the family system for the kid to get better. So including parents in the treatment is going to be really important. That doesn't mean that the parents are in all of the individual sessions, but it might mean letting the parents know what you're working on so that the parents can reinforce the use of the skills at home, not the specific content, but the types of skills that are being worked on. And then also providing skills to the parents as needed so that they can be most helpful to the teen as well. And then also keeping in mind that treatment for very young children can actually be done with the caregivers alone. So that the child does not necessarily have to present for treatment, for effective treatment of different types of mental health problems for very young children. The other thing that is common across all of the treatments is skill instruction or skill building for both the caregiver as well as the youth for the majority of treatments. Okay. Okay, so taking everything that you've learned thus far, what I'm going to do is share a case example. And then after I do, I'd like to spend some time just having you chat out what you might do with regard to treatment for this case. If this is a kid that was referred to you and you have to find an appropriate treatment given the presenting problems. Okay. So Jane is a 16-year-old white female. She was brought to treatment by her biological mother after being hospitalized for a suicide attempt. She was diagnosed with major depressive disorder, oppositional defiant disorder, and alcohol use disorder. She has no medical conditions or disabilities. She met all of her developmental milestones on time, and she does not have a trauma history. Jane reported that she had been depressed for more than a year and that this was her first attempt. She had never received mental health services before. She started drinking when she was 13 and reported binge drinking every Friday and Saturday night with friends. She also reported drinking at home alone at least one night per week. At the time of her suicide attempt, she had a fight with her bio mom and left home without permission. She split a bottle of rum with a friend. When she got home, she took a handful of her stepfather's thyroid medication. Her mother found her passed out in her room and called an ambulance. Jane's parents divorced when she was 7. She currently lives with her bio mom and her stepfather, who remarried when Jane was 10. She visits her bio father and stepmother once a month, and they remarried when she was 13, or bio dad remarried when she was 13. Jane has a 20-year-old sister who lives independently. Several of Jane's family members drink heavily, including her older sister. Jane's relationship with her mother is highly conflictual. This is her bio mom. She fights with her mother, a primary trigger for her depression and alcohol use. She's close to her sister. She views her bio father very positively, but he's not as engaged in her life as her bio mother. The males on bio's dad's side are firefighters and have close ties with law enforcement. Jane is a very social teenager with a strong peer support network. Most of her peers drink heavily at parties and encourage her to do so. Jane reported that she's the heaviest drinker and is proud of this fact. She does not spend time with peers who did not drink. Drinking when out with friends is a source of conflict with bio mom. In school, she used to get very good grades. Now she's failing 2 of 5 classes. She does not complete her homework. She has a reputation among teenagers as having a bad attitude. School problems are a significant source of conflict with bio mom. Other things that's important to know, Jane's bio dad often lets Jane down. He forgets calls, he cancels visits on her. Her thoughts reflect that she blames herself and she questions whether she's able to be loved. Jane questions whether her bio mom loves her given the constant conflict. Bio mom is a disciplinarian and bio dad prefers to act as a friend and sides against bio mom. The primary discipline method mom uses is grounding, although she typically lifts the grounding early. Jane does not think drinking is a problem. Her parents do it and on occasion will come home drunk. Her friends do it and she thinks they like her in large part because she's the life of the party. She does not think she would keep her friends if she stopped drinking. Jane's older sister drinks and used to break rules, often not getting caught when she lived at home. She tells Jane how to get away with bad behavior without her parents finding out. She also fuels the negative feelings Jane has towards her mother. Okay. So, time for you to chat it out. What are the clinical issues here that need to be addressed? Let's start with that one. There's a lot of them. Yep. We got to tackle the alcohol. Yep. Yep. Substance use, depression, suicidality, parent-child relationships. Absolutely. Yep. The child of the parents, family relationships. Absolutely. Negative peer influences, those are on board too. Yep. The peer group. Yeah, absolutely. Blended family use makes it a little more complicated. Anything else? Yeah, I mean, you're all right. She has problems across multiple areas. She's got depression. She's got alcohol problems on board. She's got acting out behavior. Yep. She's got poor school performance, family confluence, family conflict, negative peer influence, a whole host of complicated family issues, a dad that has not been paying her much attention, a mom relationship that's highly conflictual, and a sister who's a negative influence. Right. So given all that information and knowing her treatment history, which in this case, she didn't have a prior history of treatment, where would you start? When you think about the evidence-based treatments that are available in the community, which one or which ones might be most appropriate for her and her family? We got MST, we've got FFT, outpatient substance abuse. We've got core competency, CBT or DBT. Okay, of the evidence-based treatments that are, yep, we could do more assessment, substance abuse assessment, but of the evidence-based treatments that are available that we talked about, further evidence-based evaluations, yep, you could do more assessment for sure. Co-occurring family treatment and substance abuse, yep. Yep, CBT, substance abuse family treatment. Okay. So great, you guys had a lot of good ideas. So let me show you which one she had. She actually received core competency cognitive behavioral therapy. This was actually a kid that was in one of the trials for a CBT trial. And what we actually did with her, because this treatment has, we started with outpatient because she didn't have a prior treatment history. And we did a lot of teen sessions, caregiver sessions, which are essentially parent training sessions, and family sessions. And for her case, because it was complicated and because we were able to, we had one therapist work with the teen and we had another therapist work with the parent or whichever parent presented for treatment, but certainly had bio mom and bio dad in some of the sessions, and eventually the sister that was a negative peer influence. And that model actually worked really well for her. This teenager actually was on a very bad path, and by the end of treatment, she had she gave up the binge drinking. Her depression had cleared up. She didn't have any more suicidality. Her school performance got back on track. Family relationships improved, and she actually went to art school in New York. So she did much better. That's not to say that some of the other treatments wouldn't be appropriate for her as well. So MST might be something that you could try. It certainly, her profile matches with the substance abuse and the suicidality problems on board and things like that. The family may have very well benefited from the skills training in the context of that treatment as well. That could have worked. Functional family therapy might have done a good job tapping some of the externalizing stuff. It was hard to get the mom and the dad in the room at the same time, although we eventually did. So that might be a little bit of a more difficult model to use in the context of that case. But there's a number of approaches that might have worked given those circumstances. So you can see the core competency, it does depress a number of different types of internalizing as well as externalizing problems, as does DBT, right? As does functional family therapy. Now, MST, if she had, I guess she did have peer issues. Her school problems were not that significant that they couldn't necessarily be managed with a couple of meetings with the teachers, which is what we did. But if they were more ingrained and her substance abuse was even more problematic and she had a treatment history, MST might be something that may have worked, but she wasn't at that level of severity as of yet. Okay, great. So that's just an example of how you might get a case like that and the different types of options you might actually have for referral. Okay, great. So now we are going to move into a post-test, and then we're going to end up talking a little bit more, but I'm going to let Janet take it from here.
Okay, good.
There
Thank
you
you
are.
so much. I really
You're
appreciate
welcome.
it was really good to hear all this information and see it all together and be able to look at a sample case. So we have posted the post test in the chat. So please click on that link, and we're going to give you about 5 minutes or so to make sure everybody goes in there and gives us some feedback on the post test. So I will be silent for a moment and give you all a chance to click that link and fill out the post test for us. Thank you. We have about 2 minutes left. So do we have any updates on how many people have completed their post test?
We have just a handful who have completed, but a number of others who have responses in progress. There
Okay,
are a couple of open text boxes, so this one's just slightly longer than the pre-test.
got it. Thank you for the update. We'll give people another minute or two. Want to give people plenty of time to give us really good feedback, thoughtful feedback. We really appreciate that. Okay, how about now? Do we still need more time?
Maybe another 60 seconds. Looks like about half the group almost have gotten their post-tests in.
Okay, excellent.
We've had a couple of questions too about access to the slides and the recording. So I wonder if maybe we could address that too as we wrap up.
Super. Happy to do so. So one of the reasons we've been recording our trainings is so that we can post them. And I believe that we would be also able to make the PowerPoint available as well, so that people have those references. We really wanted to make sure people had the slides that might give you some information that you could share with families and some references that you could look up yourself, so that those websites might be really helpful for parents to look at, and anything that really helps everyone involved be as informed and updated as possible. So we will post the PowerPoint and also the recording. It's hard sometimes to make sense of a PowerPoint. I think this one's pretty self-explanatory, but the recording can be helpful for people if they want to hear the explanation of the slides, and the slides themselves may be helpful for participants. Again, we have been putting some of those on the CSA website under evidence-based treatment, but I think we will also post this one on the consortium website as well, since it's sponsored by that group. And we probably can send you all a follow-up email to let you know where to find those materials. So I think what I'll do is ask for, I think we've given enough time and people can continue working if they need to on the post-test. And at this point in our training, again, I will just really thank Dr. Esposito Smithers for her expertise and her really wonderful way of explaining things to all of us, so that we are getting some of these latest updates in the clinical field and the literature. And I think that's really of value to us. And the Evidence-Based Training Consortium is going to continue providing training for clinicians in the community. They have been sponsoring training like TFCBT, so that our CSB partners and clinicians in the community can benefit from all these many opportunities. So this is really helping us create the supply in the community. And then you all as case managers who refer children are able to make sure we're getting those referrals to the clinicians, so that they feel like it's worth their effort and their time, and sometimes their money. TFCBT did require clinicians to pay for some part of the credentialing. And so we want to make sure that people are sort of rewarded or know that it's important and they're going to get referrals if they proceed. So before we wrap up today, this is part of our kind of post-test, if you want to think about it that way. I'd really like to hear in the chat if there's some things that you all could share in the chat based on some of these questions. What were some of your takeaways from today's training? And I'm just going to pause with that question and see if people can jump in and add some information about what is something that you personally could take out of this training and use in your work. Just wondering if people feel like they would be able to use some of the websites. Effective treatment, childtreatment.org, I believe is the website. Some of the other places where you could go and see the listing. Do you think that would be helpful to you? I would also really appreciate it if people would, yes. So I see at least one answer that people think that those websites might be helpful. It is really important, I think, for many of the educated parents we have in our community, if they can read it themselves and they can access those materials themselves. You know, they don't always want to just say, oh, my case manager told me. And I think it can be really, it's one of the reasons why we have a professor training us is you're hearing it directly from people who are in the field doing that research and staying kind of cutting edge. So we would love to be able to have you all take a look at those and share them with families who might really appreciate seeing those resources directly. Then I'd also like to hear what you have to say about what other types of training or information do you all think that you would benefit from? Is there more that we can do to train you and give you information and access? And the same thing is with parents. We've already offered some evidence-based treatment training for parents, but I'm curious as to whether you all think your families would benefit from getting some additional training from the system. So Cheryl's weighing in about assessment tools and progress monitoring tools, and that might help parents know what to expect. I had seen Dana's question earlier about parents maybe not understanding that it would be good for them to be involved in their young person's therapy sessions, that a lot of times therapy has been demonstrated to be more effective when the parents are more actively involved. Christy, if you wanted to jump in, you're welcome to say something.
Yeah, I mean, I was going to say, even when we do individual sessions with the kids, it's always good to do a check-in with the parents for multiple reasons. One, because parents may be sharing things the kids not share. Two, as I noted, we really like to get parents involved as coaches, just so that they can be engaging in things that actually support their child in the recovery. Oftentimes we want to teach them skills as well that'll be helpful to their child. And also to just keep them informed of what's actually going on in the context of treatment. Again, not necessarily sharing the content, but of what was said in the context of the sessions, but the skills are being taught. You know, something as simple as, you know, we're doing cognitive behavioral therapy and today your child learned a problem solving skill. You know, so, you know, your child, if your child does this, this, or this, you know, these are the types of things, you know, we worked on using today to help. But what you typically do is you talk to the kid about what you're going to share with the parent ahead of time. So you're never breaching confidentiality, and it's an agreement between parent and child, or between therapist and child, before anything is shared with the parent. Unless, of course, there's a high risk situation, in which case you have to breach.
Yeah, these are good questions to ask, because we know many of our families are getting services in the community, and they're getting services from clinicians that the parents have chosen. And then, you know, sometimes we then later get the child into our system and they've already had some treatment. So you have to kind of find out a little bit more about what the parent understands about therapy and what their expectations are. My next question for you all is really around in the CSA program, we continue to see some referrals for non-specific interventions, like sort of generic home-based requests, or things that are more like supports, you know, mentoring and expressive therapies, and not necessarily as much referral to evidence-based treatments. And maybe it's just early. So I'm kind of wondering from you all if you can give me that feedback about whether or not we just need to give it a little bit more time, or whether there's something that we could do to encourage this greater shift towards evidence-based treatment. So I'm really hoping you can give me some kind of on-the-spot feedback about where you see us being in terms of transitioning. So I'm reading the chat now. I see some good feedback from Margaret Kirk. Thank you.
Yeah.
Using the a graph and some visuals. I think for everybody, you know, just seeing some positive change and getting some feedback really helps people feel engaged in their treatment. And Cheryl is also commenting on the need for positivity. I think people lose hope, or they feel maybe overwhelmed, particularly now. And Margaret's pointing out helpful to have templates of service plans specifying outcomes and sequencing. Okay, that's interesting. And you guys are more in the clinical treatment providers giving that feedback. And Anne, good point about how we encourage our evidence-based treatment providers to increase their communication regarding measuring care. Like, how can they give us some more feedback about what tools they are using to make sure they're on track?
Great idea.
And Tiffany is telling us we're still a little bit early. So give us a chance to incorporate all this into our service planning process. I think that's kind of my suspicion, is that we've pushed out a lot in the last couple of months, and given everything that's going on, it's important to give us some time. Whom is pointing out that sometimes we're starting off with the more traditional home-based, and before we move into the more specialized service, and that's fine too. Ooh, you guys are giving me some really good feedback here.
Yeah.
I don't think I could absorb it all as quickly as I need to. And Christy, feel free to jump in if you're seeing something you'd like to comment on too.
And they're all great comments.
Yeah. Fidelity pairs.
Yeah, I mean, some of the comments about encouraging agencies to train folks in EBTs, which is what we're shooting for with the training consortium. And we do hope to actually have listed providers who have been trained in the various evidence-based treatments up soon. So stay tuned for that. I know our TFCBT list is growing, and there are some folks from the community that are actually on the national TFCBT list at this point, but we're hoping to do the same thing for the other treatments as well.
So I'm looking at these last comments, and I'll just let you know, we're working on kind of on all parts of our system at the same time. So we're talking a lot with the provider community. DFS, Cindy Barker, if you know her, she's sponsored with Melody Vielbig a home-based provider, community-based provider regular meeting. We've talked a lot with them about the training consortium with George Mason. We've encouraged lots of people to participate in that. We're reaching out to outpatient therapists. And if you as case managers begin asking providers when you're calling and you're making referrals, have you been through the training consortium? Do you use cognitive behavioral therapy? What sort of evidence-based treatments are your staff trained in? We would like to make referrals towards these things. You're creating the buzz with them that they really need to get on board with that. So we really want our provider community to get the message we're seeking those services. And I really think that you all have that critical role of educating and informing parents, but letting the providers know that you know, and that you're seeking those services, and you're seeking that partnership. You're seeking measurement-based care. You're seeking evidence-based assessments. And we are willing to purchase those things. So again, the system means all of us move together in a coordinated way to make sure that we're really transforming ourselves. So I'm going to stop here. I'm going to just let you all know that I thank you so much for your interest and your participation. I will also thank our George Mason partners. What a terrific opportunity they've presented to us in our community the last few years of really transforming ourselves. If anybody has any last things to put in the chat, happy to stay on and see what people have to say. We want to make sure that you all have filled out your post-test. And Christy, anything else before we wrap up?
No, I just want to say thank you. It's been a pleasure to present for you today. And for many of you, I recognize your names. I worked with you before, and I'm thoroughly enjoying being part of the consortium and part of the community and helping you best serve your families. And if you have recommendations, please feel free to pass them along. Clearly, we provided a list of available evidence-based treatments. We'll work hard to bring more to the community. It's not an exhaustive list. We will continue to grow. We will continue to improve and expand. And I look forward to seeing many of you in trainings moving forward, hearing from you. Thank you. Thank you, Janet.
Great, everybody. And thank you all. Have a wonderful afternoon, rest of the afternoon. And we will let you know where you can find these materials later on. Thanks, everybody.
Thanks, everybody. Bye.